Hey everybody in Facebook world. My name is Laura Griffin. I'm the CEO of Frazer, and I am here with Nour. She is the Associate Director of Neurology and Radiology with UCLA, and we are here with their new mobile stroke unit. And this is thanks to the Arlene and Henry Gluck Foundation, and this is their mobile stroke program. So welcome so much.
Thank you very much. Thank you.
May looks wonderful. I ran in here at the very last second. So we're in Los Angeles, so you'll have to excuse kind of some of the humidity and a little bit of rain outside. So first of all, congratulations. Welcome to your new unit.
Thank you. We are absolutely ecstatic. This has been a dream in the making. 3 and 4 years we've been trying really hard to get the first Siemens scanner, the 32 slice scanner.
This is the very first one in the United States.
Yes.
So tell us a little about it. 3-4 years in the making. How did this all start? So we've had a collaboration with UCLA for how many years has it been?
7 years.
7 years.
Yeah.
Wow. So we're in like going into 3rd grade now, right? So 7 years is about 2nd grade. So now we're going into the next phase. So what do you think? You got to see this for the first time yesterday.
I did.
There may have been a few tears shed, and that's okay. These were happy tears.
Or more than a few.
So what do you think? What's the most exciting thing about this new unit?
Well, even just to take a step back, I'm so grateful for the advancement that the field has made in terms of mobile scanning and in terms of bringing the hospital to the patient and enabling patients to have a better quality of life, recovery, and sometimes saving from a very devastating life. And so
that's a really good point. So we've been doing this, we've had mobile stroke programs in the United States for more than 10 years. So now that we're doing this, and you've been doing it for the better part of 7 years, what are some of the advancements that you see? I mean, because when we started this, it was really tough. I mean, we were figuring it out as we went along. And what do you see as some of those huge advancements now that this new unit and this new Siemens machine are really going to be able to take us to that next level?
Yes, and I think something I cannot understate enough is that these units are only made possible by philanthropy and special project funds. So I really want to say I appreciate very much also the Brett Torino Foundation, who this is their ambulance, and our maiden voyage was with the Arlene and Henry Gluck Foundation, who has our first unit, MSU1, which we launched in 2017. We're very grateful now to advance with this state-of-the-art scanner.
You just gave me chills saying that. So you're right. I mean, these programs would not be possible without the philanthropy and without just extremely generous donations from both the Arlene and Henry Gluck Foundation and from Brett Torino, and then from programs across the United States from people who understand what time is brain really means.
Yes, and I'll add, hands in hand with philanthropy is having understanding from EMS, collaboration from our county system. I could not be more grateful for the LA County Board of Supervisors, Supervisor Janice Hahn, all the supervisors, LA County EMS, Dr. Nicole Bosson is a medical director, used to be Dr. Marianne Gausha-Hill. We've taken this journey together not only to operate these ambulances at UCLA Health, but to become a shared regional resource of LA County EMS to be part of the fabric of EMS care for Los Angeles County. We're very proud of that.
Well, see, you've been doing this for 7 years, so we got some questions through social media for people who this is really new to them. So could you just describe kind of what a mobile stroke program does? So there have been questions that have come in like, how does it work? Just fundamentally, what does this mean? And how is it dispatched? How do you interact with LA County? Like, take us through it.
What do you do? Absolutely. So, stroke is a golden hour emergency, and like all golden hour emergencies, time is of the essence, and that's what matters, to get to patients, to diagnose them quickly, and to bring them treatment quickly. So rather than waiting for the patient to come to the hospital, we bring the hospital on wheels to the patient. So basically, this is a primary stroke center on wheels. We are carrying the most advanced technology to be able to scan the patient, not only to determine whether it's an ischemic stroke, where there's lack of blood flow to the tissue of the brain, or a hemorrhagic stroke, where there's bleeding into the tissue of the brain, but we can also, and again, near and dear to my heart as an interventionalist, we can also do a CT angiogram in the field. And for the very first time in mobile field history, and thanks to Siemens, we'll be able to do a multi-phase CTA in the field. So that's the advancement.
Explain what that is for everybody out there in Facebook land, and for anybody here. What does that mean?
So not only do we need to see what blood vessels are occluded, but we need to know how the brain is compensating for that occlusion. So how fast collateral vessels come to help the tissue of the brain that's impacted. And we're very, very excited about this new Siemens advancement that's going to allow us to take better care of patients.
All right, so who all is on this stroke unit? So you have
Great question.
You have different people. Are you having are these just regular old paramedics and just anybody can just grab one and hop on in?
Yes.
Maybe not?
Maybe not. So as a shared regional resource of the county, we actually have a partnership with 8 different fire departments of the 28 in Los Angeles County. And we are very grateful for our operating partnership right now with the Torrance Fire Department and Long Beach Fire Department. And we have 2 paramedic firefighters who operate the rig, meaning that drive the rig, operate under their scope as paramedics. And then on the rig also will be a critical care or emergency trained nurse, a CT technologist, and a physician, either in person or by telemedicine.
Okay, explain that a little bit. In person, so you're not wearing this.
In
if you're on
person
the
is
rig,
the best.
you might be on something else. And then what do you mean by telemedicine?
Telemedicine. So you know what? These units, as they scale up, again, this is our 2nd unit. We're hoping to receive our 3rd unit very soon. That it becomes an economy of scales. So one physician may cover by telemedicine multiple units, and that's how we can bring the expert to anywhere the ambulance is.
So if I'm having a stroke or you think I'm having a stroke and you're not on the rig itself, how are you going to assess me?
There are video cameras everywhere in the rig. We can zoom up even to the pupil size of the patient. We're there as part of the encounter, and we're there even before the patient enters the rig. In fact, our nurses carry specialized cameras into the field, into the patient's home, into the restaurant, into the gym, anywhere where they're having a stroke, and the physician can assess with the nurse immediately on scene. And you asked a very important question about dispatch. So we are actually actively monitoring and listening to the radios of 911 services of the fire departments. We are automatically dispatched to any dispatch of stroke, or because the accuracy of dispatch still has a long way to go to dispatch specialized resources, we're attached to altered calls, syncope, seizure, headache in appropriate patients. And we arrive on scene with the fire crews. And Los Angeles is a little different than many places in the county. You may find a fire engine responding to a 911 call, and that's normal in Los Angeles County. So we arrive on scene with the first responders, determine if the patient is having a stroke, and if the patient is having a stroke and their symptoms are within 24 hours, so that we're able to offer them treatment, we admit them into the mobile stroke unit.
So if you're on the unit or if you're not on the unit, how are we getting the images from the Siemens machine to how is it? And what do the images look like? Are you looking at it on your phone? I mean, are we getting good quality images? What does that look like?
The most amazing thing that as we become mobile and we rely more on mobile devices, even this technology can come to us. So I'll give you an example. Even if I'm walking down in the halls of Ronald Reagan UCLA, rounding on the inpatient service, immediately on my cell phone, the images are transmitted over Rapid AI, which is one of the image processing software, and I'm able to scroll through the images, window the imaging, and able to identify even large vessel occlusion from anywhere I am on the earth.
Now, I mean, I've gotten to my iPhone 12 here, so I'm really a little bit behind the times. This is good image quality. You can make these decisions here.
100%, 100%. And for the first time ever, the paramedics are able to get real-time evaluation of what's happening with the patient. They admit to the patient to the unit. They don't have to wait in the hospital. They can see the scan right away. We give the medication, and they can see the patient improve right in front of their eyes. And that's remarkable. And they can take that piece of teaching to their colleagues in the fire station, and that's how we can improve EMS care as well.
So do you see a lot of pushback, or are they excited about this?
At first, it was just very novel. People would be like, who are you? Why are you showing up? What, you're taking our patient? Okay, happily, take our patient, no problem. But now we've really made a lot of strides, and many and many more fire departments are wanting to bring this to their communities and are very, very welcoming, in fact, of our collaboration.
Well, I'm assuming it's been successful because you have another unit here.
We have another unit.
And not only another unit, but you have the next step in technology.
Yes.
As you said, we're going to be able to do more on this unit.
Absolutely.
This one's a little bit larger than the last one. We've got the next step in technology.
It's beautiful.
And yes, it's got that new ambulance smell, and which is a great thing. So congratulations.
Thank you.
Anything else you want to tell us about it?
Thank you. I think this is going to change a lot of lives.
It's going to change a lot of lives.
One thing that we've actually done in LA County throughout our kind of longitudinal process of improving care is actually mapping the geospatial coordinates for where the incidence of stroke is happening within our county, to understand where these units should be most helpful.
Right.
Which
so
patients
instead
should
of
we
having
target
them
it
all
to?
go for one place, you have mapped them.
Absolutely.
Right.
So this unit is destined to go to San Fernando Valley, which is a very high stroke risk area, and also an area of socioeconomic, less availability of socioeconomic and healthcare. And also, we know that stroke affects different populations differently. So we know that there is a higher stroke rate in Hispanic population, and San Fernando Valley is overwhelmingly Hispanic in population, and we see the higher stroke rates there.
Wow.
We also have other heat maps showing that San Gabriel Valley, that would be our next target, where there are high and a lot of stroke incidents that we really need to help people there.
So this is stroke. What do you see with this that you might expand it beyond stroke or a little bit into other trauma, brain trauma?
Question.
What do you see
Great
it kind
question.
of inching out into other areas?
Yes. So to work on this concept of economy of scales, these can one day be transformable or changeable golden hour emergency response units. So from the neuro standpoint, you can help neuroepilepsy, somebody who's having status epilepticus or seizures that are continuous, that can cause brain damage. We can treat those sooner. People who are having a trauma, brain trauma, you can treat sooner in the field. And maybe one day cardiac emergencies and other type of emergencies. But I think the more patients that we can help, the more benefit we can gain from these type of units.
Well, I mean, it's fun to listen to you dream it.
Yes.
Because something like this was a dream many, many years ago.
Yes.
And now here's reality.
That's
this isn't a dream. This is
right
here after this event is over. It is going to your facility. It will be out very shortly, helping patients, helping save lives, helping quality of life, and help me, because I'm not going to get this probably exactly correct. Stroke is the #1 debilitator of lives in the United States. So the faster we get to folks, we're keeping families whole, we're keeping them in place the way they need to be.
If you want to think about kind of very sobering numbers, if we look across the group that we're in now, 1 in 4 of us right here is going to have a stroke in their lifetime. So in spite of the
very sobering, because my husband's out there, I'm right here, friends and family. Yeah, that is very sobering.
So in spite of the great strides we've made to reduce risk of stroke, we still need to do in awareness of stroke symptoms and acute treatment for stroke, because we've advanced a lot. We've advanced a lot.
Well, let me ask a quick question here. I know we have someone monitoring what's going on out there. Do we have any questions?
Any questions from the audience? We'll have you take any questions from the audience.
Does anybody have any questions? All right. Well, thank you so much.
Thank you. Lena, you have a question.
You have one?
Go ahead.
Do you have plans to figure out how to add additional units to cover the entire county?
So the question was, do we have plans, or maybe do you have plans to figure out how to cover the entire county?
Yeah.
So there you go.
Well, that's a fantastic question, Lena, because to make these units sustainable, we really need to advocate for reimbursement for these units. Although just like UCLA Health, maybe 20 or 30 other programs in the United States and in the world have mobile stroke units. They all operate thanks to philanthropy, thanks for special project funds, but we need to make sure that these are here to stay for all patients. And so one thing that will help us do that is to advocate for CMS recognizing these units as stages of care, where they are not just an ambulance, they're not just an imaging unit, they're not just a hospital on wheels, but they're a combination of all of those. And I see one day that philanthropy and health systems play a very big role in buying the hardware, but the actual billing, normal billing, will sustain, because the same activities that happen in this unit happen 30 minutes later or 45 minutes later in the hospital, and they're being paid for in the hospital. So the only way for these to survive for us is to be able to get legislative change, and we're working on that together with the PRESTO, which is the Pre-Hospital Stroke Treatment Organization, that joins us all enthusiasts of mobile stroke, is to have billing actualized. And just to give you an idea, for each minute that goes by where there's lack of blood flow to the tissue of the brain, 2 million brain cells may die. So in Los Angeles County, our average time saving of a patient who gets treated once they get on an ambulance in the mobile stroke unit versus treated when they arrive to the hospital is about 40 minutes. So we save about 40 minutes in giving the clot busting medication.
80 million brain cells.
80 million
and I
brain
don't know
cells.
what each of mine do, but I would like them. I would
Yes.
like to keep
I would
as
like to
many
keep
of them,
them.
and 80 million of them seem like they would do
Yes.
more good for me to have them than to not have them.
And not
wow,
only-
that's fantastic.
Yes, and not only can we expedite care in the ambulance, but by identifying large vessel occlusions, interventionalists such as myself are waiting in the hospital. And so as soon as we identify that LVO, we know where it is. We let them, the hospital know we're coming to you with a left MCA patient. Here's the family's number for consent, and that patient can directly go to the cath lab or the angiography suite. So in doing so, we're saving time also on the hospital side.
Wow, and that's an average. So 40
Yes.
minutes is the average.
Yes.
Could be shorter, but in reality, it could be longer.
Could be a little longer
sometimes, a little bit
sometimes.
longer.
Exactly.
So,
Exactly.
wow, that's fantastic.
Yeah.
That's a great question. Anybody else?
Any other questions from the audience?
Yes.
Is there any special training needed for the nurses, the physicians?
Excellent.
To operate the MSU?
Yeah, so the question is about special training, whether any that's needed. Honestly, from my experience as a hospital-based physician, number one thing I didn't know, why is a fire engine on a medical call? I didn't understand. Why are these firefighters? There is no fire. What's happening? And so one thing to do, the physician really needs to understand the scope of services in their EMS systems of care. Number one. Number two, we have to understand that patients rapidly progress very differently in the field than they do when they come to us in the hospital. We see them in a hyperacute stage where we've never seen them before. And so what we see on scene is a patient who's doing moderately well may 10 minutes later completely decompensate. And so things change fast in the field, stories change fast. And so that's part of what we are learning. So I really impress upon any physician or nurses or CT techs and paramedics who cover the unit to actually have the in-person experience. That is invaluable.
And I've heard physicians talk about that, the difference between,
Yeah.
and that was something when we started doing this, that we're used to working with fire departments, EMS agencies, and you were in scrubs.
Yes.
You weren't used to being in something where you needed,
Yeah.
pants that weren't going to rip and things.
Right.
I mean, what was the difference from going in a hospital setting to something where this is moving and you're going over train tracks
Yes,
and hitting
yes,
potholes? And
yes.
What was the difference in moving from one setting to another? What kind of a change was that like?
It's a huge change, and actually the huge change is we take a lot of kind of cues from our firefighter paramedics who operate our rigs. And Lena, if you want one of our firefighters to come join us, maybe you can find Mike to come join us. Yeah, so he can tell his experience, and we can even have some of our CT techs and our nurses to come join us, and then we can
Fantastic.
talk, and that will come to your question. You can ask them the questions. But
Yeah.
one huge thing is about scene safety. I don't understand that, I don't want to get hit by a car. They're like, Doc, watch out. No, don't go out this door, go out this door. You're about to fall off the rig. Oh, watch out. This is a homeless encampment. There's a needle, a heroin syringe on the ground. Watch out. So that's, Mike, come on in. Come on, tell us the perspective from fire department.
Do we need a mic?
Yeah, tell us.
Come on in. Here, you come in the middle.
I'll come in the middle.
All right. So we're talking about how the fire service has accepted these type of units. Tell us your experience in Torrance Fire and why you chose to be a paramedic on this unit.
Well, I'm grateful for the opportunity May gave because it's very rewarding. Tell you the truth, when you see somebody that's lost movement or their speech on one side, and then to be able to bring the hospital right there, treat them, get the scans, give them the drug, and I've seen the changes personally where they dead on one side and then they're moving. Or let's say the person that can't get the words out anymore and they're talking to you by the time you're at the hospital.
Wow.
And I think that right there, even if it's one person, it's worth it. But,
How do you think the crews have adapted to us being on scene with them? Do they like it? Do they hate it? What do you think?
no, I think they like it. I think it's a good integration because we are going on the 911 calls. We get dispatched with them. And we update them if we're running a little bit later, just because they're a little closer sometimes. But when we get there, the paramedics and everybody on scene, they've got a preliminary. They usually give us incredible reports, and then we take it from there. And
How do you feel that it's elevated the level of care that
Yeah.
you're giving in the field? I mean, from what when you started, you know, went to
How
paramedic
many years
school,
have you
I
been
mean,
in
were
paramedic for
Yeah.
Torrance Fire,
I've been
Mike?
at Torrance Fire for 30 years.
Yeah.
but
30
I-
years,
Yeah.
wow.
I've been a medic most of that time, but I can say, like I said, I like the fact that you see the results and having the ability to get on scene and treat them right there instead of getting them to the hospital and kind of repeating some of the assessments that were already done in the field, and it's a repeat. I mean, the hospitals are great. They're meeting quotas, getting it in time too, but you're taking just that little bit of extra, whether it's seconds or minutes, it's critical for the brain cells. So I love working here, and I'm glad to be a part of it.
Yeah, and I'll add one thing that's really important. As UCLA Health, we wanted to make sure that this is a give back to the community, not just to help UCLA patients. This is a shared regional resource of LA County EMS. We deliver patients to over 15 different stroke receiving centers in our community. And as Mike is our paramedic, and he will navigate us to the nearest, most appropriate center of care, there are very good quality measures to assure that the patients are getting where they need to be. This is, although operated by UCLA Health, we are non-denominational in terms of helping patients all over the county.
You know, you bring up a really good point. I know when we started doing this, there was concern, let's just say, among certain hospitals that maybe if this hospital started a program, that maybe more strokes would go there and other hospitals might not get them. And what we found, and this is just anecdotally, and maybe you can speak to this, is that instead of one hospital getting more, the number of strokes that were now being covered was simply going up.
Yeah.
So whatever percentage of strokes were getting intervention, now whatever percentage that was, the percentage just is going up in areas with mobile stroke units, and all hospitals are seeing it. So it's raising the bar and bringing the level up for everyone, and no one's losing out, and the community and the patients and the hospitals and everyone seems to be really being a beneficiary of that. What have you seen?
I think one really other important critical issue you bring up, that as a paramedic in the field, you can see that somebody has a weak arm or a weak leg. We don't know whether that's related to ischemia, whether it's related to hemorrhage in the brain. We don't know whether that's a tumor pressing on the brain. The very, very first critical step is getting hyperacute imaging. And thanks to this 32-slice scanner, we'll be able to do a much better job than our current 8-slice scanner. And in order to go from there, that's the critical step. Where does this patient need to go? Yeah. So one huge component of care in mobile stroke unit is routing patients, most appropriate level of care routing.
Right.
This is really, really critical.
So kind of that right patient, right hospital the first time.
Not a hemorrhage patient goes to a hospital that doesn't have a surgeon, not an endovascular
kind of, you can
patient.
get into the hospital sometimes, but it might not be so easy to get out and get to the right place that you need to go. So
wait for several hours later to get interfacility transport.
Right.
When we not only document the number of hemorrhagic and ischemic strokes, but we also document the saves in which a patient would have been routed to a primary stroke center who had a massive hemorrhage, who 15 minutes later needed to be intubated. But 15 minutes ago when the paramedics saw them, they were doing okay, so they would have gone to the wrong hospital. And now they're at the wrong hospital. They wait for hours to get transported to the right hospital, and that's not good for patient care.
Wow, and that's not even really captured in that.
No,
well, it's
not.
40 minutes instead of. I mean, those are the numbers that you don't really see, and that's fantastic that you have.
We talk about ischemia a lot in mobile stroke units. So the really important number to remember out of the BEST MSU trial, just the landmark trial for mobile stroke services, where 7 mobile stroke units around the world, including UCLA's, actually demonstrated that out of 100 patients treated earlier on a mobile stroke unit with IV clot-busting medications, 27 will have a less final disabled outcome, including 11 of whom who will be disability-free. Wow. That's compared to the same patient going to the hospital half an hour later and not getting that benefit. Wow. Same medication. The only big variable, time. We can get to patients faster. In addition to ischemia, where there's lack of blood flow, hemorrhage patients, we didn't talk about that. Wow. That's a huge field. How can you reduce the expansion of these hemorrhages or hematomas? This is not only brain saving, but could be life saving, because these can be life ending. Starting clot bust medications that reduce blood pressure immediately in the ambulance, half an hour earlier, that can save a life. Yep. If somebody's on a blood thinner, reversing the blood thinner in this ambulance can save their life. And so, again, as you asked that important question, the applications will keep expanding and expanding on what these units can do to help patients in the field.
Well, I think another important part is, besides the early treatment and tackling the problem right off the bat, is also your interaction with the hospital even before we get there, with images that they can use and take action even before we get there. So I mean, you're cutting that time down dramatically.
Yeah, who wants to do double work?
Yeah.
I mean, we want it to be lean, we want it to be efficient.
Yes.
And I mean, from a billing standpoint, to your point, you don't want somebody doing these things again, because we want to do it. I mean, everybody's heart, brain, it's all in the right place.
Yeah.
But sometimes we kind of have these impediments to get it done.
Yeah.
And on this unit, we've eliminated them. And there was one study, and I don't know who did it, that said, if you go the hospital route, maybe 12 to 14 people will touch the patient before going to have the clot removed. Here might be 3 or 4 people. So it just is streamlining it at every step of the way. And I mean, I've seen it. I've been in the back of an MSU on a call and watched it, and it's almost a dance where everyone knows their role. You've got it down pat, and everyone knows who's doing what, and it is so impressive to watch, truly. And then we have technology that continues to evolve to help that, and it feels a little bit like the sky's the limit, because here we continue to push the envelope, and that's great for everyone. So
I think as long as we keep in mind in the forefront of our mind that what we're striving for is excellence in patient care,
absolutely,
we can, with our passion, continue to drive things forward.
Absolutely.
So, excellent. Thanks for joining us,
Thank
Mike.
you. Yes, absolutely.
Any more questions from our audience? Yes.
Yes.
The new CT scanner, the advanced imaging capabilities, what benefit do you foresee for the workflow of the hospital? You have now a scanner, image point.
Yeah. Perfect. So the question from the audience was, with the capabilities of this new, much more advanced scanner, how will that affect the workflow in the hospital? And certainly, having more feeling better about the quality of the images is really huge, because sometimes people repeat images, so they say, oh, these images may be too grainy, oh, I'm not sure about this or I'm not sure about that. But if you give them definitive images from the beginning in the field, then these images don't have to be repeated. And what are we losing when the images are repeating? Time for the patient. And so now, especially with the prospect of multi-phase CTA to be a surrogate or replacement for the perfusion study, we really can cut that time short, and we don't have to have
to the whole streamline that you were just talking. I mean, that's a continuation of this, and it's just we're talking minutes, and when you're talking millions of brain cells, that is exactly what we're talking about.
And one thing you talk about improvement in technology, but also we really have to talk about improvement in teletechnology. These are mobile ambulances, so now you have much more advanced imaging that are larger files. How do you get those fast to the physician who's treating? And then also communication, telecommunication, meaning that how do you get that to the hospital who's receiving the patient? You don't want to delay care for them to repeat because they can't see images. You want to make sure that they can continue to help the patient on their journey by having it seamless. So what we've done at UCLA Health is work very closely with our collaborator Rapid AI, and any rapid receiving hospitals actually have a node, a hub and spoke node. So our CT technologist will push the images to the UCLA physician who's treating the patient, at the same time push the images to the receiving hospital who will get the patient, so they can see in real time what's happening with the patient. Thank you for your question. Any other questions? Yeah.
So somebody in the community or in a hospital wanted to start an FSC program. What are the steps, or what would be a good resource to get started?
So the question was, if someone in the community wants to start this, they're like, wow, May has just blown us away, we're ready to go. Now what do they do?
Now what do they do?
That's
great question. I will say all politics are local. That's how it is, right?
That's right.
So the first thing you have to understand, who are the stakeholders in your communities and how to get them on board. It's much better to work with your collaborators and engage them and bring them on board than set them aside. So I highly, highly recommend these units to be kind of a shared resource unit, a collaborative unit, not only belonging to one health system and taking to 12 health system. It should be really for the stroke community within that region. That's one thing, the stakeholders and getting them on board. Second thing, you need money. How are you going to get the money? So you have to have visionary philanthropists like we have the opportunity to have in UCLA Health who really champion this cause. And a health system that's appreciative, understanding, supportive of this. Look into integration with EMS, the EMS medical directors in your community, how do they feel about it? Bring people such as ourselves who had that experiences, who've gone through the uphill battle, who've come on the other side and have had success. And in joining something like Presto, the pre-hospital stroke treatment organization, you have camaraderie of all mobile stroke units, not only in the US, but around the world. And we can all learn a lot from each other.
Well,
Okay,
thank you so much. This is wonderful.
It's a
Congratulations.
pleasure. Congratulations
We can't
to you
wait
too,
Yes,
Laura.
it's been a lot
And
of fun.
Lena,
we
come say
can't-
hello.
Yes,
We gotta
come on.
introduce Lena on camera. And Jens, please, come.
right.
Come, we want to introduce you.
Oh, yes.
And we want to know about your role at Siemens and what you've done to see this scanner be a reality.
And talk that way loudly.
Yeah, talk loudly.
I'm more than happy to see all of you and to introduce the scanner on the MSU in the first time. It's really a happiness for me.
Yeah.
And I'm responsible for the program management for mobile CT within Siemens Healthineers, and this makes me proud that I'm part of this team.
Yeah.
And thank you to you, thank you to Laura, thank you to May to make it happen together with us and to provide the MSU to the patient, which can save lives.
Thank you,
Jens. exciting.
And Lena, introduce yourself, please, and your role at Siemens.
Oh, it's nice to see you. My name's Lena Saran. I'm the Business Development Manager for Siemens here in the United States. So I've been working very closely with Jens at the headquarters in Germany, and have known Nour and Frazer for many, many years. We're all extremely passionate about mobile stroke, and we're thrilled with the partnership that we have, and looking forward to building more awareness for mobile stroke units, and taking on even more challenges and innovations as we move forward. So
Thanks to these incredible partners, they really made our dream come true. I can't be more thrilled. Thank you all for joining
Exciting.
us.
Thank you.
Thank you.
Okay.
Thank you.
all.
Right. Thanks, Tom. Give me a big hug.
Jens, you're
I feel like
famous.
this is-
You're famous, Jens.
Doesn't matter.